So, diabetes group 4, proceed.
Good morning, class. Good morning.
Good morning.
Okay, thank you. So, my name is Crispin Barasa, actually the group leader of group 4, and I want to present on diabetes mellitus. We have type 1 and type 2. Just an overview. We want to discuss about we want to define what diabetes mellitus is, the mechanism of diabetes mellitus, its causes, and we'll move on and look about the types of diabetes mellitus, where we have type 1 diabetes mellitus and type 2 diabetes mellitus, where we'll look about the pathophysiology and the pathogenesis. So, diabetes mellitus is a group of metabolic diseases characterized by elevated level of glucose in the blood, which we call the hyperglycemia, resulting from defects in insulin secretion, insulin action, or both. So, first, we have two types of diabetes. We have diabetes mellitus and we have the diabetes insipidus. So, diabetes mellitus is a disease that is caused by, it is actually one of the homeostatic imbalance disease, where the normal negative feedback mechanism is overwhelmed, and that destructive positive feedback mechanism is actually takes over, causing harm to the body. So the main cause of this diabetes mellitus is the insulin hormone, where we may actually have the actually being produced not in enough quantity, or maybe there is an insulin resistance where the adipose tissue or muscles become just resistant and cannot respond to the produced insulin. So what is insulin? Insulin is a hormone that is secreted by beta cells, which are located within the clusters of cells in the pancreas called the islet of Langerhans. Insulin role in the body is to trigger cells to take up glucose so that the cells can use this energy, yielding sugar, and also to control the level of glucose in the blood. This is done by regulating the production and storage of glucose. So insulin is a hormone that works under the negative feedback mechanism, where when the level of glucose in the body is elevated, it is actually secreted by the beta cells, of the pancreas. We have the alpha, beta, and delta cells. So insulin is produced by the beta cells of the pancreas, where it is used to control the level of blood sugar in the blood. So how does this work? When the level of sugar in the blood is elevated, actually the hypothalamus, which is the control center found in the brain, is actually stimulated by an impulse, where it now sends impulses to the pancreas to produce insulin hormone into the bloodstream, where now the elevated glucose will be converted to fats and other to glycogen and stored in the liver. So say that, for example, those people who have HIV and AIDS, actually their immune system normally becomes weaker because of the white blood cell actually trying to fight with those viruses. And now when a person with HIV and AIDS now maybe reach at the, let's say, full-blown stage, and maybe he or she is attacked by TB, now is when death can come in easily. So diabetes mellitus may cause death. Of course, when it reaches at the severe point, we have those diseases that may arise and leading to death. So diabetes mellitus is a major cause of morbidity and mortality resulting from related diseases that develop from the chronic diabetic mellitus or long-term effects. So these are some of the diseases that can develop when a person has this diabetic mellitus, when it actually elevates to a chronic level. So This includes of large blood vessels such as macrovascular diseases, including coronary heart disease, which is a cardiovascular disease, and peripheral arteries disease. So this coronary heart disease, actually, it is the one that is 75% cause of death for these patients that are suffering from this condition called the diabetes mellitus. Those are the condition for the large blood vessel or macrovascular diseases, and we have those for the small blood vessel or micro diseases, which are including the retinal, where in this circumstance we call it the diabetic retinopathy. The diabetic retinopathy, where there is actually a damage to the eye. And we have the renal vascular disease, actually, when it is elevated and it cannot be controlled, actually the kidney will overwork and will actually lead to a chronic kidney failure. And also, the next disease is actually the nerve, the disease of the nerve. So up to there, we have actually defined what is diabetic mellitus is. We have just its cause, actually insulin, when there's insufficient insulin production, or actually the adipose tissue and the muscles just become resistant to the produced insulin. Now we can move on and look at the mechanism of diabetes mellitus. So for the mechanism of diabetes mellitus, so in diabetic mellitus, the body fails to regulate the amount of sugar in the blood, and then the blood delivers glucose to provide the body with energy to perform daily activities. So actually, the blood definition of blood is that the blood is a circulating tissue, and actually it has three main functions: transportation, we have actual regulation, and we have the protection. So this blood is the one that is supposed to actually transport that glucose that is actually formed by the liver to the body tissues, actually, which acts as a fuel, where the metabolic reaction will occur, producing energy in form of ATP, which will help in continuing the homeostatic actually reactions in the body. So the liver converts the food taken in by an individual into glucose, and then the glucose is then released into the bloodstream. So in a healthy person, the blood glucose level is regulated by several hormones, primarily the insulin, which is released by the pancreas. Insulin allows glucose to move out of the blood into cells throughout the body, where it is used for fuel. So people suffering from this diabetes either do not produce enough insulin when the body now is not when now the beta cells or the pancreas is not able to produce actually the sufficient insulin. You may end up suffering the first type of diabetic mellitus, which is the type 1, or when now the body becomes resistant. Now the body, those adipose tissue and the muscles now become resistant to the produced insulin, or just it is just insufficient or indeficiency. Now that is when we come to a type 2, the diabetic mellitus. So in diabetes, glucose in the blood cannot move more efficiently into cells, so blood glucose level remains high, which we call it the hyperglycemia. And what happens when the blood glucose remains high? It will actually cause harm to the organs, cells, and tissues. Now we can proceed and move and look at the what causes this diabetes. So patients with diabetes may have dysfunctional beta cells, resulting in decreased insulin secretion, or their muscles and adipose cells may be resistant to the effect of insulin, resulting in a decreased ability of these cells to take up and metabolize actually glucose. So when just like the way I have said, we have type 1 diabetes mellitus, and we have the type 2 diabetes mellitus. So the type 1 result from when there is when the beta cells are destroyed and they cannot produce enough insulin that is actually able to control that blood glucose, that elevated blood glucose. Now, in this scenario, is like when the destructive, the positive feedback mechanism is actually taken over, and that normal negative feedback mechanism is actually overwhelmed. So in both cases, the level of glucose in the blood increases, causing the hyperglycemia. So the pathophysiology of the type 1 diabetes mellitus and the type 2 diabetes mellitus is the same, but the difference where the difference comes is when the pathogenesis is under the pathogenesis. The cause what results from this diabetic mellitus 1 and this type 2 diabetes mellitus. So here I want to look at the signs and symptoms. So as glucose accumulates in the blood, excess level of sugar are excreted in the urine, what we call it the glycosuria, which is a symptom because of the greater amount of glucose in the urine. More water is excreted with it, causing an increase in urine volume, polyuria, and frequency of urination, as well as thirst. Now, other symptoms of diabetes include itchy skin, we have hunger, we have weight loss, and we have weakness. So, under the symptoms of this diabetes mellitus, this is under now we normally have 4 stages. We have that stage of susceptible. Now, when you become just susceptible to a certain condition, we have that stage of subclinical, we have the clinical, and we have that recovery, death, or disability. So, some of the symptoms, actually, we have the glycosuria. The glycosuria is when now the kidney overworks, and now it is not able to actually reabsorb that glucose in the blood. Now more of it is being excreted, and when more glucose is being excreted, of course glucose has a higher osmotic pressure than water. Now it will tend to absorb more water from the body, which will actually cause thirst, which is another symptom. So for thirst, we normally call it the polydipsia. Actually, the polydipsia is when there is increased thirst. Glycosuria leads to polydipsia. How? Glycosuria is when there is actually glucose is being excreted through the urine. And when glucose is being excreted through the urine, actually more water will actually be absorbed through osmosis, thus leading to actually increase in the volume of urine and actually the frequency of urination, actually leading to we call it the thirst. The other symptom is the polyuria. Actually, I know everyone understand what polyuria means. Actually, when there is increased urination, polyuria is increased urination. We have the polyphagia. Now, polyphagia is when more glucose is being excreted. Now it will lead to increased hunger. Polyphagia, what I mean is that there will be an increased hunger. So other symptoms, we have headache, have blurry vision. Blurry vision is when we have the diabetic retinopathy, damage to the eye. Fatigue, we have slow healing of cuts. When you have a cut, it takes long to heal. We have weight loss, we have weakness. Yeah, those are the symptoms. Now, I'll move on and now look especially for these two conditions that we were assigned. We have the type 1 diabetes mellitus and the type 2 diabetes mellitus. So here I will move straight to I will just define the condition. I will just define the condition. look at the pathogenesis and look at the pathophysiology. Actually, the pathophysiology, as I have said, of type 1 and type 2 are like the same, but where the difference comes is when there is actually there for the pathogenesis. So type 1 diabetes mellitus. So it's also called the insulin-dependent diabetes mellitus or juvenile onset diabetes, and it's usually onset in childhood. So what causes this type 1 diabetes mellitus is usually caused by autoimmune destruction of the isolates of Langerhans of the pancreas. So autoimmune destruction, this time we actually have those autoimmune diseases. Autoimmune is now when the immune system actually malfunctions and it mistakenly breaks down and destroy its cells and tissue. So patients with type 1 diabetes have serum antibodies to several components of the isolate of Langerhans, including antibodies of insulin itself. The antibodies are often present for several years before the onset of diabetes, and their presence may be associated with a decrease in insulin secretion. The actual destruction of the isolate of Langerhans is thought to be caused by immune cells sensitized in some way to components of isolate tissue rather than to the production of autoantibodies. So most patients present with symptoms of hyperglycemia, while some other with diabetic ketoacidosis, which is an indication that insulin secretion has significantly deteriorated. Now, you will allow me to look about the pathogenesis. Actually, what leads to this? What leads to the origin of this diabetic type 1 diabetic mellitus? Now, we have that in that condition where you just become susceptible. You just become susceptible where you have the genetic predisposition. We have genetic predisposition or susceptibility. So what happens when we become just susceptible? You become susceptible to things like we have environmental insult or environmental insults such as viral infection or toxic chemicals, or autoimmunity such as the lymphoid infiltration or insulitis. So when you become susceptible, so for example, for viral infection or toxic chemicals, actually there will be an immune response. And what will happen when there's an immune response? Actually, we have isolate of Langerhans, antibodies will be produced, and cell-mediated immunity. For the immune response will actually lead to beta cell destruction. When the body moves toward an extent of producing actually antibodies to the isolate cells, there will actually be destruction of beta cells. There will actually be destruction of beta cells, which actually produce this insulin hormone that help in the regulation of blood glucose. And when there's destruction of beta cells, we know that there will be actually a lack of insulin release. And when there's a lack of insulin release, it will lead to an insulin-dependent diabetes mellitus, which is the type 1 diabetes mellitus. Now, that is the pathogenesis. You become susceptible. When you become susceptible, those viral infection, they cause an immune response. When you have an immune response, you actually lead to destruction of beta cells. And when you have the destruction of beta cells, it will actually lead to lack of insulin release. And when there is lack of insulin release, or actually it's released but not in the sufficient amount to control that level of blood sugar, is now when you just suffer from this type 1 diabetes mellitus. What is the pathogenesis of this type 1? So if the amount of insulin available is insufficient, the glucose will not be absorbed properly by the body cells. Now, the net effect of persistently high level of blood glucose, poor protein synthesis, and breakdown of fat storage will actually lead to acidosis. So now, when the glucose concentration in the blood remains high over time, the kidney will reach a threshold of reabsorption, actually leading to a symptom called the glycosuria. And when there is actually, and this will result to increase in the osmotic pressure of the urine, actually leading to a polyuria. Actually, more water will be absorbed from the body, leading to a polyuria. Where when I say polyuria, I just mean that there is increased fluid loss, which may lead to actually thirst or polydipsia. Now, the lost blood volume will be replaced osmotically from water held in body cells and other body compartments, which can lead to dehydration, or what is polydipsia. Now, this can cause death. Actually, when now you are excreting a lot of glucose, it may lead to death. Of course, those cells, you will become hunger, and then the body will not be able to actually carry those daily metabolic reactions to produce energy, or to supply cells with glucose to carry those metabolic reactions, and it can lead to death. So that was about the type 1 diabetic mellitus, where I have just discussed about the pathogenesis when you become susceptible, actually the immune response, destruction of beta cells, lack of insulin release. You just suffer from that condition, diabetic mellitus 1. And the pathophysiology of this is the amount of when now the beta cells have been distracted. Now there is no more production of insulin. The glucose level increases, actually what we call the hyperglycemia. What happens when the glucose level increases? Actually, it will accumulate. It can accumulate. Actually, those ketone bodies can accumulate in the body, leading to what we call the ketoacidosis. When there is a ketoacidosis, actually more of it will be excreted. Actually, when there is actually a kidney failure or a chronic kidney failure, will lead to actually more glucose will be excreted. What happens when more glucose is excreted? Also, more water will be drawn from the body, will be drawn from the body and also excreted, leading to thirst, and you become dehydrated. What happens when you become dehydrated? You can die. You are just now be susceptible, and you become more likely to
Yes,
die.
we can continue with type 2 diabetes.
Okay, Stephen, you can proceed.
Yeah. Type 2 diabetes mellitus. It is formerly called non-insulin dependent diabetes mellitus or adult onset diabetes. It becomes more common with increasing age. It is associated with obesity resulting from insulin resistance or insulin deficiency. Insulin resistance is very common characteristic of type 2 diabetes in patients who are obese, and thus patients often have serum insulin concentrations that are higher than normal. Some obese persons are unable to produce sufficient amounts of insulin, and thus the compensatory increase in response to increased blood glucose concentration is inadequate, resulting in hyperglycemia. Many patients with type 2 diabetes are asymptomatic, and they are often diagnosed with type 2 diabetes when routine measurements reveal high blood glucose concentrations. So let's talk about the diagnosis of diabetes. Diabetes is usually discovered when there are typical symptoms of increased thirst and urination and clearly elevated blood sugar level. The diagnosis of diabetes is based on the presence of blood glucose concentrations equal to or greater than 126 milligram per 100 ml after an overnight fast or on the presence of blood glucose concentrations greater than 200 milligram per 100 in general. People with fasting blood glucose values between 100 to 125 milligram per 100 ml.
Excuse,
Eh?
excuse, Steve,
Hey,
I think you should actually talk about the pathogenesis of type 2 diabetic mellitus and the pathophysiology of the type 2 diabetic mellitus before you move on to the diagnosis of diabetes.
okay, so
So I can help you. Let me help you
yeah,
talk about the
What's happening?
So, excuse me, doctor.
Yes?
So actually, he has moved to diagnosis of diabetes,
Okay.
but he has not actually talked about that, how the pathogenesis and the pathophysiology of this type 2 diabetes mellitus.
Okay, proceed.
So let me just briefly, just in 2 minutes. Now, the type 2 diabetes mellitus is actually caused when there is actually insulin resistance, when the adipose tissue and the muscles now becomes resistant to the secreted what? Secreted insulin. Now, when the causes is that there is actually obesity or hereditary factors. Now, when there is obesity or hereditary factors, there actually be an insulin resistance where there is the insulin resistance. Maybe it may be caused by the receptor defects or other events, or there may be delayed or actually insufficient insulin secretion. What happens when there is insulin resistance? Actually, there will be increase in insulin demand by those adipose tissues and the muscles, which are actually not able to carry out actually their metabolic reactions. This may be caused by beta cell exhaustion or dysfunction. And when there is beta cell exhaustion or dysfunction, there will actually be an impaired secretion of insulin. What happens when there is an impaired secretion of insulin? It will actually lead to a hyperglycemia, increased glucose level in the blood. When there is increased glucose in the level in the blood, it also leads to this now the type 2 diabetes mellitus, called the non-independent diabetes, non-insulin dependent diabetes mellitus, which actually occurs mostly for those people that are above 40 years. That is for the pathogenesis. Obesity, insulin resistance. Actually, for the type 1 was actually insufficient. Insulin is sufficient. Actually, autoimmune destruction of the beta cells. And this now is about the insulin resistance, which all of them actually leads to a hyperglycemia, increased glucose level in the blood. Now, what is the pathophysiology of this type 2 diabetes mellitus? Now, if cells respond poorly to the effect of insulin, or if the insulin itself is defective, the glucose will not be absorbed properly by the body cells. Now, the net effect is persistently high level of blood glucose, poor protein synthesis, and breakdown of fatty storage, which is the acidosis. Now, when the glucose concentration in the blood remains high over time, the kidney will reach a threshold of reabsorption, the glycosuria, actually urination of glucose, excess glucose, and this increases the osmotic pressure of the urine polyuria, which actually increases the fluid loss. Now, this one results to lost blood volume will be replaced osmotically from water held in body cells and other body components which will actually lead to a dehydration and polydipsia. And these can actually move on and result to death if not treated. Yeah, I think that is the pathogenesis and the pathophysiology. Now Stephen can continue.
Stephen? Continue.
Yes, I'm here. So we can continue with the diagnosis. Diagnosis of diabetes. Diabetes is usually discovered when there are typical symptoms of increased thirst and urination and a clearly elevated blood sugar level. The diagnosis is based on the presence of blood glucose concentrations equal to or greater than 126 milligram per 100 ml after an overnight fast, or on the presence of blood glucose concentrations greater than 200 milligram per 100 ml in general. People with fasting blood glucose values between 100 to 125 milligram per 100 ml oral glucose tolerance test, in which blood glucose is measured hourly for several hours after ingestion of large quantity of glucose, usually 75 to 100 grams, are used in pregnant women to test for gestational diabetes. The duration and severity of hyperglycemia can be assessed by measuring levels of advanced glycosylation and products. AGEs forms are formed when hemoglobin molecules in red blood cells undergo glycosylation binding, which is the binding to glucose, and the bound substances remain together until the red blood cells dies. A glycosylated hemoglobin called hemoglobin ALC is particularly useful in monitoring hyperglycemia and the efficacy of diabetes treatments. After that, we have the treatment of diabetes. The first point, untreated diabetes leads to ketoacidosis, which is the accumulation of ketones and acid in the blood. Continued buildup of these products of disordered carbohydrates and fat metabolism result in nausea and vomiting, and eventually the patient goes into a diabetic coma. Treatment of diabetes mellitus is aimed at reducing blood glucose concentration to normal levels. So we have diet and exercise, and also insulin therapies. There are some drugs which can be used. There are several classes of oral drugs used to control blood glucose levels, including sulfonylureas. We have the beguanides, thiazolidinedons. Yeah, those ones. So I think that one marks the end of our presentation.
Okay. Okay. Diabetes mellitus, type 1, type 2 diabetes mellitus. Type 1, which is an autoimmune disease, leads to absolute insulin deficiency. Usually, as it has been said, for the type 1, there is autoimmune destruction of the pancreatic beta cells. That's in the islets of Langhans, which is as a result of genetic predisposition and some other environmental factors like viral infections. Because of that, that autoimmune reaction, there will be damage to the insulin-producing beta cells, and the beta cells mass will decrease. Insulin secretion will decrease, also will fall dramatically, and that's going to result in hyperglycemia, as now glucose uptake into the muscles and also into the fats is impaired, and that now presents with the symptoms that were presented. The type 2, which is a metabolic disorder, usually because of or characterized by insulin resistance, or there is a relative deficiency of insulin. So various factors can cause that. But now talk about things like the obesity, which will affect now the insulin binding to its receptors being impaired. Over time, there is beta cell dysfunction, exhaustion, which leads to progressive insulin deficiency. The liver will increase the gluconeogenesis, which will worsen the hyperglycemia. Mostly, type 2 is associated with the metabolic syndromes like the obesity, the hypertension, dyslipidemia, and manifested by those symptoms, the oliguria, olphagia, polyuria, polyphagia, and polydipsia. So any question to that point? Mika Simiyu. Mika Simiyu?
Yes.
Yeah.
An addition. Okay, like you say, the causes of the diabetes mellitus too. There is where I found the certain point like gestational diabetes mellitus, where they were talking about increased glucose levels in blood in pregnant women, or we can say that in expectant mothers. So like they were saying that during pregnancy, we have some hormonal changes, which some hormones are produced by the placenta, like the progesterone, estrogen, and some growth hormones. So the hormones, they were saying that can have the anti-insulin effects, which might reduce insulin sensitivity, leading to a condition known as physiological insulin resistance, which ensures that there is more glucose which is available, because we all know that in expectant mothers, they need a lot of nutrients because they also share with the fetus. So on that point, the pancreas has to increase the production of insulin in some, which in some cases, because because of the hormones, the hormonal changes, we've said that there will be insulin resistance. So the the body tissues will be resistant to insulin, meaning that the glucose levels will be very high in the blood, which later, maybe after birth, if they've said, okay, as Crispin said, if the cells are damaged, the beta cells, that means that the glucose will not be absorbed or reabsorbed into the body completely. That means that it might be a predisposing factor of diabetes mellitus too. Yeah, that was my point.
Thank you, Mika. Yes, we have gestational diabetes, which is another type of diabetes, but this one now is commonly seen in pregnant women, where they develop the high blood sugar levels during pregnancy. Usually, the gestational diabetes happens from around the 24th week of pregnancy, but sometimes it will get to resolve after delivery. But again, it increases now the risk of one developing the type 2 diabetes later in life, mostly caused by hormonal balance, the hormones. The hormones that sometimes are produced by the placenta get to interfere with insulin, which now makes it less effective. But again, genetics and also lifestyle can play a role in gestational diabetes. Then there is another question. Can you explain how diabetes leads to diabetic ketoacidosis and why it's more common in type 1? So I know we'll be getting to that later on, but basically diabetic ketoacidosis, that is now a complication of type 1, mostly a complication of type 1 diabetes. It's a serious and life-threatening complication of diabetes. So with the diabetic ketoacidosis now, happens now when the body doesn't have enough insulin to allow now glucose to get into cells for energy. And as a result of that, the body now will start breaking down fat for energy. And with that breaking down of fat for energy, it will lead now to production of ketones, which are acidic. And those ketones now will build up in blood, and that's going to cause acidosis. So that's why you talk about diabetic ketoacidosis. Keto from the ketones, acidosis from the acidity that now is produced from those ketones. So mostly diabetic ketoacidosis will come in for those individuals who have missed the insulin doses, so they have failed to take their insulin as it should be, or those who have undiagnosed the diabetes, all the diabetic patients, but who now experience physical or emotional stress, or some cases of infections like the UTIs, the pneumonias, can also lead to diabetic ketoacidosis. So on your diagnostics, of course, you will see elevated blood glucose levels more than 13.9 millimoles per liter. The arterial pH will also be decreased, which is now because of the acidosis. You will see positive in urine sample. You'll see that urine test or urinalysis, you'll see that there will be positive ketones in the blood, or actually in blood or in the urine. So patient, of course, will experience now excessive thirst, excessive urination. We'll talk about deep, rapid breathing, which we'll refer to as the Kussmaul's respirations. There'll be alteration in the mental status of your patient as part of those manifestations of diabetic ketoacidosis as a complication of diabetes. Another question? Crispin?
So my question is, we have actually patients with diabetes mellitus, we are actually supposed to actually administer insulin in form of an injection. I think so. So can you help me to actually just become familiar with that actually parts of the body where we can actually inject?
Parts of the body where you injected the insulin.
Yeah.
Okay. Anybody who can tell us which are those parts? Parts of the body where you can inject insulin. I'm sure this is some of you should be familiar with it. Yes. Who is that? There's a hand up. Precious, yes, your hand is up.
You can inject insulin in the thighs, the upper arm, the gluteus, and the abdomen.
Okay. Yes, those are some of those sites that we can inject, but the abdomen is the most preferred site for injection. But again, you can do the thighs, like Precious has said, the front or outer part of the thighs. But now absorption is lower than the abdomen. The upper arms, that's the back or the outer part of the arm, where we have the fatty area. Also, but absorption still will be slower. It's moderate absorption compared to the abdomen. The buttocks, the upper out quadrant, where there's still slower absorption. So the most preferred site is the abdomen. So we'll come to that again when we come to medical surgical nursing. We'll be talking about management now of diabetes. The long-term complications of diabetes. We'll come to these things later on. We are on pathophysiology, but then there are quite a number of long-term complications, and usually we classify them into two. We talk about the microvascular complications and the macrovascular complications. If you talk about the microvascular complications, they affect the small blood vessels. So we'll be talking about microvascular, the small blood vessels. We'll talk about diabetic retinopathy, where there is now damage to the retinal blood vessels, and that can cause loss of vision or blindness. We have the diabetic nephropathy, which affects the kidneys, so the glomeruli, which can progressively progress to chronic kidney disease. We have the diabetic neuropathy, which affects the nerves. Usually now, the peripheral neuropathy and the autonomic neuropathy. So those are the microvascular, which affect the small blood vessels. Then we have the macrovascular complications, which affect the large blood vessels, like cardiovascular disease, where one has an increased risk of heart attacks, heart failure, atherosclerosis. We have the cerebrovascular disease, where there is an increased risk of now stroke or the transient ischemic attacks. Then we also have peripheral arterial disease, which now affects blood circulation. So there'll be poor circulation, more especially in the legs, and that can lead to foot ulcers, the gangrene, and eventually one can potentially be amputated. So those are the long-term complications of diabetes. And I think somebody has again put that in the chat box. So another question, I believe we have exhausted. I want us to end it here for now.